down their throat. Okay? Because with the stridor, we know that the airway is compromised. So I've got to open it.
They actually had my patient in the OR have that during the surgery.
So they did, yeah, because they didn't put him.
They just put
Right. Because even though he didn't have general anesthesia, he had some type of anesthesia, local or regional or whatever, he still was at risk for not being able to maintain his airway. Okay? So they just use that as opposed to intubation. So do you think that the post-op nurse is going to have these LMAs around right there readily available? Because when she hears that stridor, she's going to get one and she's going to cram it down the throat because that is a sign of airway obstruction. I do not want you saying, well, it could be caused by the laryngospasm, or it could be caused by, I don't care at this point what's causing it. It's happening, do something. Okay? We've got to get that airway open. Okay. All right, so I think I've stressed a lot about airway. All right, now let's look at cardiovascular. We talked about this. Do y'all know what pulse pressure is? You ever heard of the difference in pulse pressure? The pulse pressure means that is a difference between the diastolic and the systolic. All you do is subtract them. There it is, math again. All you do is subtract those numbers. Okay? No multiplication, no solving for x. Just subtract the numbers. So if you get the blood pressure, it's 120 over 80. I subtract 120 or 80 from 120 and I get 40. So with 40, that to me, I better be looking at some cardiac issues. That is a sign to tell me that my patient has now, could have had some respiratory issues, but now we are going into some cardiac issues. Okay, so that's going to be a sign through your assessment that now this respiratory problem has turned into a cardiac problem. And we have got to start moving. The patient, you might see or you might see the nurse to start, one of the first things she'll do is start putting some fluids in. Because if that the pressure in the heart is not at an adequate volume, so it's probably because that they had not got enough fluid. So that may be one of the first interventions that you see that nurse do to help pull up that pulse pressure. And think of it the same way as if your patient was hypotensive. If your patient was blood pressure of 80 over 40, what do you think one of the first things you're going to want to do? Push fluids, right? So when the pulse pressure is low as well, it's probably coming from an issue with fluid. We also think about that patient just coming out of surgery, maybe hemorrhaging. So it's going to give me some more evidence through my assessment that can help me document that this patient may be hemorrhaging, because I can't always see blood inside somebody, can I? So I got to go on this, don't I? I got to go on that blood pressure. I got to go on that pulse pressure. This is what I'm going to say, and at that point, when we start getting into trouble, we pull that fluids up, and then we know that there's a cardiovascular problem, and then we're going to probably get into some trouble. Okay? So you have got to make sure. I think I want you not just to say, okay, this is happening. I don't want you to say, okay, this is happening. And I heard this in the test review. You're wanting to know a cause of what's happening here. Yes, eventually I want you to have the knowledge, but what I want you to know is to be able to recognize that this is abnormal. This is not right. A pulse pressure of 40 or less is not right. Then you will anticipate that you've got to do an intervention. You've got to do an intervention.
Is it 40 or less or greater than 40? If theirs is greater than 40.
Greater than 40.
Okay.
Yes. Did I say less than? Yes. You know, my mind says one thing, or my mouth says one thing and my brain says something else. No, it's higher. It's the higher here that we're worried about, not the lower. Okay? So if I have a blood pressure of 180, well, let me go backwards. If I have a pressure of 100/40, 100/40, when you're assessing that, is that a good vital sign? No. But look at the pulse pressure is 60. So that is giving you more evidence to show you that there's not adequate cardiovascular system working. Does that make sense? Okay, so that's more evidence. The blood pressure is low, but you're also going to say, what's the pulse pressure? And if you get it higher, then it's going to be, we've got to do something.
Okay, because to me, when I look at the blood pressure, the blood pressure is fine. So I'm basing this off of.
Restate that.
Okay, so I'm just looking at this 120/80.
Mm-hmm. You're okay with that blood pressure, is what you're saying.
Right.
Yeah, I'm not really concerned about that blood pressure at this point.
Right.
But I'm more concerned of the pulse pressure right here. Because you know, when we look at our whole assessment, we got to look at everything. I'm reassured that the pressure is 120/80, but I'm not reassured with the pulse pressure. Okay? Does that make sense? No, still not getting it.
I have one question. On the vital sign machine at work, then there's an MAP number. Is that what that is?
Mean arterial pressure. No, that is not what that means. The MAP is the mean arterial pressure. It's different than the pulse pressure. That is going to give me another, because that is straight arterial, not anything else. You will learn that your senior year.
Okay.
Yeah.
So if their pulse pressure is 40, we are okay for now.
I'm okay with that.
But it goes higher than
Yeah. And I think that's what I was trying to say, because I'm not really worried about 40.
Right.
But when it starts getting 50, 60, 70, then I'm going to start.
I think if we see a pressure that is indicating that more has a pulse pressure higher than 40, we're probably going to need to do not see the difference.
Right.
Just because it's equal. But if you take on the blood pressure, you see
But the blood pressure is also not right, but the pressure is not all right.
I'm trying to just see the difference in the numbers. You're going to be able to look at say,
Right.
that's a big difference in numbers.
The greater the difference, the systolic or the diastolic, is one of those is going to be out of the range by what you're saying.
Yay! Putting things together. All right, so increased pulse, we talked about that. You may also see that the patient is on a cardio monitor, so they will be able to pick up if they're having any arrhythmias. Now, I think I've talked to you about arrhythmias and dysrhythmias. You know that you can't diagnose a dysrhythmia or an arrhythmia. You know you can't do that, right? But what you can do is you're feeling it and you know that there's irregularities there. Then you know you've got to get the monitor. So the monitor is going to tell you the irregularity that's there. Does that make sense? So your patient is coming out of the OR with the probes on, and they are going to reconnect so I can see exactly what's going on with that heart. I'm going to see that monitor. I'm going to see if he's in V-tach. I'm going to see if he's in atrial flutter. I'm going to see, it's going to alarm, and it's going to say, dang, 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 atrial flutter here. It's going to tell me what's abnormal. That is not your scope of practice right now. All right, so trivial vascular. We've got to look at the color of the extremities, and you're doing a full head-to-toe assessment on your patient when they come out of the OR, especially if they've had any type of orthopedic surgeries. We've got to make sure that there is adequate perfusion and adequate blood flow to the areas. Now, I think we've talked about Homenstein.
I can't remember.
Somewhere.
I can't remember what it is, but
Okay.
it's familiar.
No.
That's suspect.
Homenstein is when you have your patient pull their toe up, and then back behind here, they're going to have pain. Now, DVTs, immediate post-op, you're not going to see a DVT. So it may be days after the surgery, you may see a DVT. But the thing with, if the patient pulls their foot back and they have pain in their calves, that is something that in the post-op period that you have got to notify the physician. A lot of times I always say, you did this, you assessed this, what intervention are you going to do? Homenstein is one that I have got to notify the physician. But I've also got to look for other signs and symptoms, which would be what of a DVT in the lower extremities? Tender.
You won't feel the pulse very
The pulses are going to be diminished. There's going to be pain. Bad perfusion, but come on, what are you going to be feeling?
Cool.
It's going to be hot to touch. Hot to touch. And will there be any edema?
Yes.
Yes. So at the DVT, I need you to understand what is very, very common with patients who have surgery. You have got to make sure that when you check that Homenstein that there's no, that if the patient says, oh my God, that hurt me, well, obviously stop. Then you go to the extremity that he's saying that there's pain in. You feel for warmth. You look for edema. And a lot of times when they have a DVT, it's like a hot spot. So it's sort of like you can tell exactly where that clot is. And see, guys, do you understand what can happen if that patient is developed a clot? And it starts moving. So I'm telling you now, if that patient has a positive Homenstein, one time, don't do it again. Okay? If it's documented positive, because what are you doing? I'm sitting here doing this right here.
You're moving it.
I am encouraging it to let go and fly to the lung, or the heart, or the brain. So you see why I'm saying, once you get it documented one time, don't do it anymore. What you need to do with that positive Homenstein after you've assessed is you need to call the physician and say, look, it's got a positive Homenstein, there's redness there, there's edema there. You're telling him all this information because this is very, very common. And what do I do to help prevent this from happening? Not sit them up. What do I do to prevent a DVT from happening in my patient? They may be on anticoagulants. Huh? How? Pulsatile stockings. Absolutely. They are going to come with those stockings on, and they have to be kept on every time they're in the bed. TED hose. Put TED hose on. Pulsatile stockings. Do y'all know what I'm talking about when I'm talking about pulsatile stockings? Yes. Same thing as STDs. Say it all the time. You know what I'm talking about? You know those little things you put on, it increases your circulation. So wouldn't you expect this? They blow up. Yeah. Because when the patient's in bed, that's going to increase their circulation to prevent blood clots. So, what's another thing I want to do? Ambulate. Get my patient up. Now, if they can't get up, you got to move them. But, if you have a positive Homenstein, don't you get that patient up. And don't put your pulsatile stockings on. Because what that's doing is it making that break up and shoot out. And you go to the brain. important. So you're going to put it on the other leg, but you're not going to put it on that one because the purpose of the pulse to the socket is to prevent it from happening. If it's already happened, then I can't be doing a bunch of Holman sign and doing a bunch of range of motion and doing all this kind of stuff on if he's positive for a blood clot.
This is random. I had a patient with a drop foot, and he couldn't do the flexing. What do you do if he can't do that?
You cannot move that foot because once they're dropped, you cannot pull that foot up. So you have to go on other signs like the redness, the feel. Absolutely.
He had these shoes though that had springs in it.
Try to bring them up. Most of the time when patients get foot drop, it's very hard to correct. Very hard. The foot just absolutely drops and you can't get it to come back up. And those are seen with patients who are bedridden for long periods of time. All right, neurological. We've talked about level of consciousness. You've got to make sure that they're easy to arouse. We know that restlessness is going to give us another sign of hypoxia. Absolutely. All right, movement of extremities. Now we just talked about that. If the patient can move, I've got to move their extremities for them. I've got to get that blood circulating. This is also important when you have a patient who has an epidural or a spinal. They won't be able to move those legs because they can't feel them. So I'm going to have to do, what's that called?
Passive range of motion.
Active range of motion with them. Passive range of motion. Y'all quit saying words to confuse me. Passive range of motion with them because I've got to get them moving so they don't get the side effects or the things that happen, or the complications happen with surgery. I've also talked about if they have an epidural, don't get them up until they have full sensation in their lower extremities. And when they have spinals, how long are they going to lay flat? At least 6 hours. Absolutely. All right, fluid and electrolyte. We got to be watching this as well. Do you think the CRNA is going to give us a really good measurement of what went in and what came out when they were in the OR?
Yes.
Because hydration is very, very important. You may see a big difference, though. You may see the fact that the patient got 5 liters, which is 5,000 mLs in the OR, and he's not putting it out that much. So you would expect your patient to have some edema. Okay, they will start doing some third spacing going on. Especially you'll see the edema in their face. So one of the things I need to watch is I've got to really, once I start, not the immediate post-op, but once I get them up to the floor and start looking, I got to really keep an eye on that fluid. Okay? And I'd also keep up with the vital signs because that vital signs is going to tell you about fluid volume issues. Okay? So you've got to keep up with those. Hydration. Most everybody that comes out of the OR has got a dry mouth. Okay? And it's because, that doesn't mean you're going to pop them with a bunch more fluid. You're going to make sure that that fluid that they got in the OR is coming out. Okay? You may have to get some Vaseline for them, but fluid volume is so important. I've got to check their turgor, especially on my older patients, because those are the ones that are going to get in a fluid volume problem quicker than my young adults. I've got to watch my older ones. They'll get it, and if we get fluid volume problems, we've got to have cardiac problems, and the snowball just keeps getting bigger and bigger and bigger. Okay, I just put what we use for fluid that you'll see for fluid replacement. All right, acid base. You've had enough acid base. And labs. Renal, control of their bladder may not return for 6 to 8 hours. This is what we were talking about if a patient has a epidural They don't know if they need to pee or not, so we're going to make sure that we offer the bedpan to them and make sure that their fluids are coming off. The other thing is you want to make sure is that they have obviously 30 cc's an hour, but if a patient has, in the post-op period, has a Foley catheter in the OR, they generally wait till the next morning to take the catheter out. Now, you got to remember, they've been about 24 hours with the Foley. Do you know how long it takes for that sphincter to get lazy?
A couple hours.
I'd say minutes.
Oh, wow.
Because that sphincter that controls our urine going out, it gets that tube in there and says, oh, I don't have to work no more. And so then when we take the catheter out, it still don't think it has to work. So it takes a long time to retrain our sphincter to get rid of that urine. You just have to remember, you can't let this patient go for hours and hours and hours and hours and hours without attempting to get them to use the bathroom. Okay? When I hit about 6 hours after my patient's Foley's taken out, I get a little nervous. Okay? But I'm not going to wait that 6 hours. I'm going to start asking them as soon as they get back, do you feel like you need a potty? Do you feel like you need a potty? I'm going to start doing measures like getting them up to the potty, sitting them on the potty, pouring cold water between their legs, turning the water on, putting their hands in water, doing anything that I can do to help them pee. And a lot of times when I say to them now, you've got 6 to 8 hours that you've got to pee on your own before I put that catheter back in. And that usually scares the pee out of them. Because they don't want that thing back in.
It did with my patient last week.
You scared the pee out of
I
him?
kept
Yeah.
asking him and had him baths and I kept saying drinks. And finally I said, I said, you have 6 to 8 hours to pee after your butt's removed. If you don't, we have to put another one in. And right at 6 hours he peed.
Good. So we scare the pee out of our patients because if we immediately say we're going to put that catheter back in, they're going to be, I'm going to do whatever I can to go pee because I do not want that back in there. And I don't want to put it back in because that's another invasive procedure and that puts them at risk for having a UTI. So make sure that they have PP. There she goes again. All right, GI. Let's talk about GI just a little bit. Now, when patients post-operatively, or when they go through surgery, you know the valve stops. Okay, the valve. So I can't tell you enough that you better be on those valve sounds because patients can develop an ileus, which is a little obstruction in their valves, so you have got to keep up with making sure that they have valve sounds. Now, guys, if they've had valve surgery, do you think that those valve sounds are going to come back immediately?
No.
We got about 24 to 48 hours before 24 hours, I don't get concerned because I know that could happen. But what I will be doing is doing what? Getting them up. I'm not going to let them sit in there because I know getting them up is going to assist them in being able to get those valves to moving. Okay? You cannot not assess valve sounds. This is one time that you say to your patient, this is a good time to poot. So you want them to poot. I go in there and say, have you pooted yet? Come on, let's go. We got to get this, these poots going. So they'll start pooting first, and then they'll start getting their valves to going. So I'm always encouraged when I get a poot. All right, NG tubes. Y'all talked about NG tubes. I need to reiterate about NG tubes. Are we good on NG tubes? We know that we're going to check placement, right? Except when they're in those. Going back. Have y'all talked about the different colors of drainage when it comes to an issue the different types of drainage that you need to be looking for. I can tell you that coffee ground secretions or drainage is never good. So when you see a patient, let's say you're looking at, because you know you assess the drainage of the patient who has an NG tube, that's output. You got to keep up with that output. But if you ever see anything that looks like coffee grounds, and you know what coffee grounds look like, that is from an old bleed. There is not one nursing intervention that you can do at this point. You immediately call the physician because there is an old bleed and there is a problem, and that patient may end up having to go back to surgery. So if you go in there and see this coffee ground and say, oh, I think I'll give them some more fluids, or I'll make them start drinking, or I'll get them up. Not with this assessment. Coffee grounds are not good. Call the physician at that point. All right. Here I go again. All right, skin, integumentary. You know wounds are going to take a long time to heal. It may not be completely healed up to 6 months. Now, it takes about 2 weeks to get just the top layer of it good and closed and stuff. But I'm still going to see some other things that I need to assess for on that incision. Have you ever heard of Rita? You know what Rita is? Redness,
edema,
ecchymosis, drainage, and approximation. Every time that you have a wound, you are to assess Rita and document. Once you have any abnormalities there, then you need to have them addressed. The drainage-wise, you need to assess the drainage. You need to tell me what does it look like. Here is the drainage. What's normally expected is Sarah sanguinis. That's a little bit of bloody tint to it. And you would expect that as soon as they come out. Then it's going to change to Sarah sanguinis, which is a little bit thinner and just a little blood tinge, not a whole lot of blood tinge. And then it goes to serous. That is normal for the first couple days. I also want you to make sure when you're looking at dresses that you smell it. And I don't mean like this. I need you to, when you pull back, because one of the first signs of having an infection in that area is an odor of drainage. And it stinks like, everybody's had snotty noses or bronchitis and they cough up that stinky mucus. You know what I'm talking about? Have y'all not smelled that? It like stinks. Nobody's had a stings in their nose. Okay, thank you. You know what I'm talking about? That's what it smells like. You know what infection smells like. No,
Bad
I don't
breath in
expect
your
you
kids.
Huh?
Bad breath in your kids when they have it.
Absolutely. It stinks, and you should always be smelling. And no, I don't mean get down on your patient all in the wound. You know when you pull that dressing off that you're going to be able to smell something. You'll smell it. Not as bad as C did, but you'll smell it. Okay? All right. A little bit of crusting on the incision line is normal, and pink at the incision line is normal. A little bit of swelling is normal too. But you've got to learn at any time when you're in this profession, if you have a wound that you're not sure, because sometimes it's hard for you to look at something and say, is this really something I need to worry about? Go talk to somebody. Get another nurse to come in there and say, I just need y'all to look at this wound. Or when the doctor makes rounds, could you come up here? I'm a little bit concerned about this. Just to make sure that we're not missing an infection that's getting ready to start. Because the sooner we find something abnormal with an infection, we can get it early. So beyond looking at this wound, smelling it, looking for Rita, making sure that it's good and healing the way it should be. The other thing is patients need to be educated. Before we send them home, we've got to educate them on what a wound is supposed to look like, and if there's anything abnormal, they need to contact their physician. Very, very important in post-op, because sometimes infection happens after they go home, and I can't have that happen. All right, so we know one of the things that can happen with a wound. How am I doing? As far as getting done, I'll take a look. They took my time. They took my time.
You have 17 slides left.
Okay. All right. Two of the most important things when it comes to wounds. Have y'all had skin yet? Have you talked about dehiscing? Have you talked about evisceration? Okay, so you know what I mean when I'm talking about dehiscing. So the patient with the wounds, I need to listen to these words. If I ever hear any patient say to me, I'm getting ready to pop open, I feel like all my intestines, you better listen to that patient. I had a student a couple years ago, we were in the, have I told you about the little 12-year-old I had? Okay, she had surgery, big old incision here. And she was about 4 days post-op or whatever, 4 or 5. Doctor says, we want to take those staples out. And I was like, I just really don't know how I feel about that. I don't know. So I go in there and I start talking to her and I start assessing. I look for Rita. Little redness, but I would expect it. But her abdomen was sort of distended. And then I looked at her mom and I said, I didn't want to say, is she normally this heavy? But I said, look at her belly. Does it look like it's bigger than it normally is? And her mom said, well, maybe a little bit, but not a whole lot. So I'm thinking, okay, well, at least she was a little bit chunky. So I was going on that. No redness, but she kept saying to me, I feel like I'm going to pop open. So I talked to Dr. Newman. I said, really, come in here and look at this with me, because I just don't think that the staples need to be removed right now because of her saying she feels like she's going to pop open. Oh, she's fine, da-da-da-da, she's only 12, da-da-da. I'm like, you're not listening to me. You are not listening to me. So anyway, I go in there and I had my student with him. I was like, yeah, we don't get to take out staples. And then I started looking at the situation, and I thought, have the student dehiss or have the patient dehiss or let the student take out the staples. What is my priority here? So I said, okay, I'm taking out the staples. And when I take out staples, I say every other. I don't know if you've been taught that before, but I take every other. I don't go, straight up the line. So I took this one and at the bottom and I clipped it out. And I looked at my student. I said, I need some gauze. So I'm talking to the little girl. She's telling me I'm getting ready to pop open. And so as I popped that one, which I was sort of glad that I popped it because all this drainage was coming out. All this drainage. And you didn't have to get down there and smell it. Because it was thick, green. We're talking 4 days. 4 days after her surgery. So I just very calmly put, some gauze up there, looked at the student and said, I need you to go get me some more gauze. And then I said, can you hit the call bell, please? And so the call bell, I said, get Dr. Newman in here now. Very calmly. Well, he comes in here raising Cain. Why have you not got those staples? I said, we had to take that poor youngin' back to surgery. And he wanted to take every one of those staples out. Didn't listen to me. I should have never even, but I was sort of glad I did take that one out so things could start moving and getting out of there. But the thing of it is, guys, is when you have, and I just had a gut feeling, something ain't right. I mean, it's like I have a gut feeling that something went right, but I didn't let the student do it. I did it and got that straight, and we had to take her back. So when that patient the moral of the story, when that patient tells you, I feel like I'm gonna pop open, listen. The bad thing about that is it happens about 7 to 10 days after surgery. And where are they at?
Home.
They're at home. And how do you educate a patient about that? Because it's scary. But I still got to do it. And I don't say to them, you know what? It's going to pop wide open and your intestines going to go flying out. I don't tell them that. I just say, look, this is one sign and symptom that if this starts happening, if you ever feel like it's going to pop open, I just nip it in the bud like Barney, then and say, call somebody. Go back to the OR, or the ER, wherever. Go. When anybody says that, I feel like it's going to pop up, I don't take a chance. I've got to get them back because they know their body. They know what's getting ready to happen. They've got to get help. That's a dehiscence. Evisceration is when the actual organs come out. So, now, let me just tell you, we don't always carry sterile gauzes with saline in our pocket, do we? Okay? But that is what we're supposed to do. As soon as it happens, we are supposed to put sterile, moist gauze over the organs. Now, mind you, some people are at home, and they don't have those equipment either. So, in the NECLEX world, everybody with me, in the NECLEX world, you know, we have everything at our fingertips. We don't have to ask for anything. So, when NECLEX asks you, when you've got a patient who's got an evisceration, what are you going to do? You are going to put sterile, moist gauze on it. Right?
Yes.
In the real life, we start praying to Jesus, and we grab anything that we could possibly grab to hold those organs and scream like the good Lord gave you that big old mouth. I need help in here. Then somebody can come get us the gauze. Okay? This is a major emergency patient. You're going to have to go back to surgery at that point. Okay? But we've got to keep moist, sterile dressings on it and continuously. I've even had to pour saline in the abdominal cavity. I want the patient back in the bed, flat, or a head elevated a little bit, and keep that area as clean and sterile as I can get it around here. Okay? I've even had to just take normal saline and pour it in the abdominal cavity just because I couldn't keep enough sterile dressings on it to keep it moist. Okay? So it's a major, major emergency. I need you to understand that that is something we need to do about it. It's very painful. It's very painful. And what I would like to do is knock my patient out right then and there.
Do they not pass out from that?
Not always. Pressure. Oh, yeah.
So, this, like, I graduated school like 6 years ago, and it's always kind of been like, evisceration doesn't really happen anymore. Like, it's, you know, it's just happening. Well, one day, I guess it was last summer, so it was really recently, we had a trauma come into the OR, and they're like, it's a post-op patient that's eviscerated, and we're like, okay, it's kind of like the ED and our nurses are like, you say this, we don't believe you, you say this, you don't believe us. So we're like, whatever, not a big deal. The lady had an exploratory lap, which is like if you get in a car or something and they don't know what's wrong, they just cut your entire abdomen open to look to find whatever's spread you open. So they didn't really find anything that day, stapled her shut. She went home after she was released from the hospital. And she went to her surgeon that morning and had her staples out, and she had told the nurse, like, she didn't really feel right. She felt like her stomach was going to pop open. They looked at it, it was fine. So they took the staples out. She went home, her husband went to work, like, you know, she's about a week post-op. She's doing all right. So the nurse told her if she felt like she could take a shower at some point, she could. yesterday on the period and after, and like, you need someone there. Even though you had your safety belt, you still need someone with you. Well, her husband was at work, she went to take her shower, and when she turned the water on and stood up in the shower, her incision popped open. And I mean, this is like a good 6-inch at least incision that's literally, if you're in an emergency, we just cut through it. There's no like taking your time, it's not, and then they use the thickest sutures or just staples. There's not like good healing in it because it was so traumatic. So she fell in the shower, passed out, like called 911 when she woke up. And when we got her to the OR, like they bring her in like an aluminum blanket, like we call it foil blankets, like a heated blanket like you see on TV. So my nurse and I like transferred her to the bed and pulled the blanket back, and we were like literally gagged out because her entire everything was just out. And she's been saying that, but we take it as like a patient saying it as opposed to a nurse. It's kind of like, you know, they'll have like a 1-inch gap and be like, oh my god, my belly's hanging out. Like, no, everything was out. Because we have PRN nurses that are retired, and they're like, I haven't seen this since the 70s or 80s. Like, it doesn't happen anymore. And there's, I mean,
It does happen.
yeah, because people aren't educated. The office nurse, which in her, you know, mindset, she's probably like a medical assistant or something. They don't really have nurses in offices anymore, take my example. So she probably didn't really know the severity of it anyway. It was fine. Doctor said take him out, take him out. And the lady didn't
No
know. She thought
assessment
she was
skills.
healing. Yeah. So, and I mean, she lived and everything, but, you know, that was like a slight heart edge. We thought she had something wrong. She was fine. She was healed. She went home. She thought she was fine. Her husband thought she was fine. And then it's like, it just went completely downhill.
So that's what I'm saying to you guys. It happens now. When she's saying it doesn't really happen much anymore, and the reason why it's less seen is because of the research that they've done on the sutures and the thickness of the suture. There's like, oh yeah, that doesn't work anymore. Let's don't use this. We need to get this thicker. So there's lots of research, and we're changing the way that we close patients back up. But I'm telling you guys, listen to your patient. I know I am a major advocate of listening to patients because they know their body. They know what. Why do I go in there and ask them 85,000 questions if I'm not going to listen to what they say? You know, listen to them. If they ever say that, it happens. So, moving right along. Dressings. Is everybody seen drains? Do you know what I mean by a hemovac? So everybody knows what a hemovac. If you do not know what a hemovac looks, it looks like an accordion. I need you to go to your clinical instructor and say, show me a hemovac. When you have, it looks like an accordion, and it's actually, the drain is put into the beside the surgical site, and the object is that to pull the drain, if there's any extra drainage in that area, pull it out. So if that drainage sits there, it's going to cause infection. So it pulls it out. Do you know how to close them and open them? Okay. There's a little pop top on it. So when you get ready to empty it, because that is output, okay, you are going to document that patient had 130 cc's of serosanguinous drainage out of the hemovac. So it's supposed to be closed when you get to it. You pop the little top, and when you pop the top, the accordion opens. Then you drain it, count it, assess it, and then for you to be able to make the suction happen again, you've got to squeeze the accordion and pop the top while you're squeezing it. It's got to maintain that suction because that suction is what's pulling that drainage out of it. It's the same thing with the Jackson Pratt. Jackson Pratt looks like a bomb. You know what a Jackson Pratt looks like?
It's like a grenade.
Yeah,
Like that.
like a grenade, a bomb, or whatever. I always say bomb for some reason. But it looks like it's just a little, a very
Bulb.
thick
Little bulb.
plastic bulb. And I've got to get you to understand that that's assessment of the drainage, and you've got to count it, and you've got to look at it, and look at that drainage spot and assess what that drainage looks like.
I had my patient last week had back surgery, and he had one of those. But he had a lot of bleeding during surgery, very bleeding blood. But every time you squeezed it, it would fill up within seconds. So we actually
would make it pull more. So I need you to understand, do you know what all the drains look like? If you don't, go to your instructor, have them look at it. If y'all are in surgery, you want to know what one looks like, I'm going to get one, and we'll look at it. All right, pain, I'm not talking about pain, y'all know pain. Psychosocial, where am I at? Pain, psychosocial, I'm not talking about that. You know lab values are majorly important. I mean, I like preach this and preach this and preach this. But what you've got to remember is when you're looking at lab values for a patient, you need to look at what their lab values were prior to the surgery. That is what you're going to look at to see what is going on with that patient. I.e., you need to know what the patient's H&H was before surgery, and then you are going to have the surgeon is going to order lab values to be done first day post-op, second day post-op. That's going to give you some more evidence to see if that patient's hemorrhaging. It's also going to give you more evidence, and you're going to start talking about this, and Ms. Beaver will be proud because I'm actually mentioning it. An early sign of infection when you're looking at lab values is the increase in the bands, which is an immature neutrophil. It is called a left shift. So when you're looking at your lab values, look at those bands, and when they start increasing, they may increase before your WBCs increase. So that's going to give you another bit of information. She's going to go more in depth about the left shift, but you're going to see that over and over and over. Nursing diagnoses, y'all can read those. Wounds, we talked about wounds. I keep repeating myself. Okay, we can do that. Multiple dressings, we've already had those. Drains, we just talked about those. You may see some antibiotics given prophylactically. Did I talk to you guys about the research about the giving the antibiotics in the timed? I talked about that. So that's actually cutting down on infection as well, and it's cutting down on the patient getting large amounts of antibiotics after surgery as well. Sorry, I didn't get your question, baby. You sure? All right. We just talked about de-hissing, evisceration. Why do I repeat myself? We discussed this. Is that it? No. We know about Narcan because I've thrown that down your throat in the meds. And health teaching. So it's all about in the post-op area, the acute situation happens acutely and they get them to another floor. But there's things that tell me the most important things that you're going to be looking at to help prevent a patient getting any complications of surgery. What would be one of the number one complications?
Airway.
Airway, which would be they might get. What's the complication of pregnancy? What's the complication of surgery? Respiratory problems, so they might get into respiratory distress, which then it
Decreased
may cause them
perfusion.
to get
Hypoxic.
and die. We're not dying today. Pneumonia. Pneumonia as respiratory thing. Respiratory. So tell me ways I can prevent them getting pneumonia.
Incentive
Turn,
spirometer.
cough, deep breathe. Get them up. Incentive spirometer. Flutter valve. Something. Get them up. Don't let my patients that are in surgery stay in the bed. What's another complication? Blood clots, absolutely. DVTs. You read my mind, didn't you? What am I going to do for a DVT? I'm going to prevent it from happening. I'm going to put my pulsatile stockings, my TED hose. I'm going to early ambulate. I'm checking for Holman's. Range of motion if they can't. So post-op is the biggest thing, is preventing complications from happening. I've got to be aggressive, assertive, because I can tell you, when I had my hysterectomy and those nurses said, get out of bed, I said, absolutely not. I'm not getting up. I am not getting out of here. My bottom hurts, my back hurts. I'm not getting up. We have got to educate our patients on how important it is. Just a little bit of explanation. Do you know getting you up will help prevent pneumonia? Using this incentive spirometer can help prevent you getting pneumonia. So it's all about prevention of things happening as complications from surgery. All right, I think I'm done. Any questions?